Hi, my name's Dr. Joseph Best. I'm an oral and maxillofacial surgeon in Waukesha, Wisconsin. And along with Russ Dunkel, we're going to present management of dental pain in the emergency room. And we decided when we were putting this together to expand what we're talking about, to just talk about the kinds of things that I'm sure that emergency room physicians throughout the state see, including issues of dental infections. And then talk a little bit also about how to give various blocks to provide local anesthesia for these patients. So we'll start out just by talking about a patient. So this might sound familiar to you. John is a 36-year-old male. He presents to your emergency room at 10 p.m. on a Sunday night in severe pain from a lower tooth that has been a problem for several months. He has noticed increased pain and swelling over the past 24 hours. And so this type of a presentation, this acute dental pain that's gone unmanaged for many, many months and then becomes a crisis, is the kind of thing that I'm sure that you folks have to manage. I know I have to manage in my practice all the time. And so I just want to go through managing this type of patient. How do you go about selecting a local anesthetic for this patient? And how do we manage the analgesia for a patient like this? And then I'll also talk a little bit about infection and antibiotic selection for these types of presentations. So I think the first thing is just to understand dental pain. And we know dental pain is largely an inflammatory issue. And if we look at what's actually happening in a patient like John, is that at the apex of that tooth that's infected or the tooth is necrotic, where the pulp dies and causes inflammation, are lots of pro-inflammatory cytokines that are expressed at the apex of that tooth, and those and cytokines actually change the neurochemistry of the neurons that are in the area. They activate and sensitize the free nerve endings there. They increase spontaneous activity, and they actually decrease the threshold for firing for those teeth. And so what this produces is a diagnosable problem called hyperalgesia. And once this occurs, and you have this cascade of events that produces these pro-inflammatory cytokines, you get pain that becomes very difficult to manage. And we'll talk about some of the ways that you can approach that. Now, one of the issues that we're having, and I don't need to, I'm sure most of you, if you open up a newspaper these days, know that we're having issues with prescription opiate abuse. And part of that, and it's a larger problem both in medicine and dentistry, but a portion of that is opiates that are prescribed for patients for dental pain. When you look at where patients are getting these prescriptions from, they can be getting them for themselves, and they have leftover from this crisis dental event. But they also can get them from other people that have prescriptions for opiates. And all of this is leading to problems with patients abusing these drugs. And the problem is a certain percentage of patients who abuse prescription drugs will ultimately go on to abuse injectable narcotics like heroin and others. And this has led to increased numbers of deaths from heroin overdose in Wisconsin. And so one of the things we're trying to do is get people to understand the risks of these prescription drugs and perhaps look for other avenues, other treatment strategies that maybe don't involve prescription narcotic medications. So the first wave of overdose deaths that happened in Wisconsin was from prescription opiates, but as things have evolved, and a significant percentage of these prescription opiate abusers have switched to heroin, now we're starting to see heroin overdoses going up, and then with the synthetic opiates like fentanyl, you're starting to see deaths from the synthetic opiates like fentanyl. But all of this, these increased numbers of deaths from these drugs are leading to, led to regulators and people at the state level trying to come up with solutions to solve this problem. And so that's why we have talks like today to talk about how can we manage dental pain without utilizing these medications. And also, you can see that this is just an example of increased overdose hospital visits involving heroin. And again, we're seeing an increase in that mainly because we're probably doing a pretty good job at starting to curb the prescription opiates, and that is leading now to higher numbers of patients abusing heroin. And I don't need to tell a group like yours about the increased utilization of emergency rooms in the state for dental pain. These are patients, for whatever reason, socioeconomic payer groups that just find difficult to get access to routine dental care, end up having untreated dental pain that ends up in the emergency room. And so, how are these managed? Well, they can be managed with opiates to help manage their pain. They can be managed with antibiotics. They can be managed and referred to local dentists. But we're going to talk about some strategies that you can use that maybe give you alternatives to utilizing opiates in some of these patients. And this is just an example of what we're seeing now is certainly in dentistry, but they're also seeing it in the medical side, this decrease in the number of prescriptions that we're getting with opiates. And this is a good thing. This is what we want, and this is what the state has been striving for. The only problem with that is it's led to patients that have become addicted to prescription medications now looking for other narcotics to abuse, and then you get into heroin and fentanyl and the overdoses that can result. And so when I speak to dentists about this topic, I always talk about, a lot of dentists think that they're a really big part of the problem. This is a physician problem, but clearly you can see that there are a lot of patients being given opiate prescriptions for dental pain. And so it's 9% of the opiates that are prescribed. So it is a significant problem. And after we finish today, hopefully you'll maybe develop some strategies to use alternatives to opiates in these patients. And again, we are seeing this decrease, just like with physicians, in prescribing these medications. Now, I'd like to start out by talking about when you have these patients in the ER with a dental emergency, typically it's going to be pain, where you want to provide local anesthesia to get the patient temporary relief until such time that they can be seen in a dental office to have definitive treatment of whatever the dental problem is. And to do that, we need to use local anesthetics. And I just want to give you a dentist perspective on how we see utilizing local anesthesia for these patients. And to do that, we have to remember how these drugs work. Local anesthetics, they block sodium channels by actually getting into the nerve. And so a nerve's got the bilayer lipid membrane. That drug has to get and diffuse through that bilayer lipid membrane to actually plug up the sodium channel from the inside. And that becomes important when you're talking about patients with dental infections. Because the problem with dental infections is they tend to have a pH issue. So when you look at a drug like a local anesthetic, these are all charged ions. The reason when you look in a bottle of lidocaine, it's a clear fluid. It's an aqueous solution because it's acidic, and that's why it kind of burns when you actually give a local anesthetic injection. And so it's this charged molecule that's in the local anesthetic you inject into a person. The problem is the charged molecule does not diffuse through the bilayer lipid membrane very effectively. It has to lose the proton in order to become more lipophilic and get into the nerve so it can block the sodium channel from the inside. The problem is dental infections tend to have a lower pH. And so it messes up the chemistry of the local anesthetic you inject when you're injecting into inflamed and infected tissue, which is usually what you're going to be managing in an ER situation. So just be aware of this problem, and it means that local anesthetics tend to take longer to take effect, and they also they tend to not last quite as long. Now, you can improve this situation when you take into account the pKa of the anesthetics. Now, all the pKa tells you is how easily does that proton come off that local anesthetic molecule. And so we want to have a pKa that gives the best advantage of that proton being lost so the anesthetic can be more effective in an infected and inflamed environment. So that's the issue when we're talking about selecting an anesthetic to treat these patients. And so the pKa is going to determine what percentage of those molecules are going to be either charged or uncharged. And when we look at the local anesthetics that are commercially available for dentistry, mepivacaine, carbocaine, has the lowest pKa. And that means when you're in an infected and inflamed environment, mepivacaine is going to penetrate the nerve better and provide more profound local anesthesia in an infected and inflamed environment. Now, you're probably looking at it and go, well, 7.6 versus lidocaine, which is 7.7, but you have to remember that this is logarithmic. This is a logarithmic difference. So studies have shown that actually there is a significant improvement with achieving profound anesthesia in patients with infected and inflamed environments when you use mepivacaine over a drug like lidocaine or articaine. Now, one of the problems you can have, a drug like mepivacaine is available without epinephrine. It's also available with neocorbephrine. The problem also with inflamed tissues is they're quite vascular. And so when you're doing these injections and providing people anesthesia, you need to have a vasoconstrictor present because you will have very short duration of your local anesthesia if you give an anesthetic, for example, like mepivacaine plain that doesn't have a vasoconstrictor. You'll maybe achieve 15 minutes of anesthesia. It's just not going to last very long because of the vascularity of the inflamed site. So you need to have a vasoconstrictor to prolong the duration. It also antagonizes just the natural vasodilatory effects of the local anesthetic. It'll decrease bleeding, and it'll also decrease systemic toxicity. And this is through an alpha-1 receptor activity. The agents that are typically used in dental anesthetics are going to be epinephrine or neocorbephrine. We don't use norepinephrine anymore because of all the side effects. And these things, as you know, they're all sympathomimetics. And so when you have patients that have certain medical issues, there can be contraindications. So the vasoconstrictor is contraindicated in patients who have untreated pheochromocytoma, anybody who has unstable angina, uncontrolled hypothyroidism, MI within the last 6 months. We try to really avoid giving any kind of vasoconstrictors. Frankly, we avoid elective dentistry in these patients. Now, if you're in an acute situation where you got to get people out of pain, obviously the pain itself is a huge stimulant of the sympathetic nervous system. In that situation, you can certainly give some vasoconstrictor if you need to get somebody comfortable, but they need to be used with care. So in patients where, for example, that have a significant cardiac history, significant hypertension, we like to limit ourselves to 0.04 milligrams, which is roughly 4 cc's of 2% lidocaine with 1 to 100,000 epinephrine, would be about 0.04 milligrams. And that's for patients where you're concerned about increasing sympathetic tone and the risks of their blood pressure going up and heart rate going up after giving the local anesthesia. Obviously, there's a significant drug interaction with patients on beta blockers, in particular the non-selective beta blockers like propranolol, because what you get when somebody's on a beta blocker, you're going to get a pure alpha response in those patients, and that their blood pressure can go up quite significantly. This is not a problem with the cardioselective beta blocker. So when we look at somebody who's on a non-selective beta blocker, your both beta 1s and beta 2s are blocked. You inadvertently give epinephrine intravascularly when you're doing a dental block, and they will get a pure alpha response. Their blood pressure will go up pretty significantly because you don't get the balancing effect of the beta 2. So if somebody's on a cardioselective beta blocker, then you have the beta 2 receptors, which are also stimulated, and those are also in your skeletal muscle, and they produce vasodilation in your skeletal muscle. The alpha 1 constriction will be balanced by the beta 2 dilation in the skeletal muscle. So that's not as big of an issue. Just be aware of the patients on the non-selective beta blockers to limit epi because of that drug interaction. Now, I'll go through a few different anesthetics and give you advantages, disadvantages, maybe areas where you might want to utilize one versus another. I'm sure, and having done plenty of stuff in the ER over the years, it would appear to me for most people that lidocaine is kind of the workhorse, and it is for good reason. It's relatively inexpensive, it's effective, it's got a working time that works well for closing lacerations and doing things like that. But it's not the only anesthetic available, and so what I teach our dental students at the dental school is that there are other options, and there are certain times when one may have significant advantages over another. But lidocaine certainly is a very nice, for a typical dental block, you're looking at about 60 to 1 to 2 hours of pretty significant anesthesia for the patient, and then gradually tapering off after that. It's available in both 1 to 100,000. I wouldn't encourage you to use the 1 to 50,000. That's usually just used for bleeding control in certain situations. But certainly the 1 to 100,000 is what is routine, the 2% with 1 to 100,000. Bupivacaine, Marcaine is something that I would really encourage you to use. It comes as a 0.5% with 1 to 200,000, and is going to give you the longest local anesthesia that we currently have, other than a drug that I'll talk about a little later. But bupivacaine is one that if you have a patient coming in, especially for a lower tooth, where you're going to do an inferior alveolar nerve block, you're going to get a good, profound anesthesia for 4 or 5 hours. And that oftentimes can get the patient to a weekday or a time when they can get to see a dentist to get the whatever the painful source is managed. I would be careful. We try to avoid mepivacaine in pediatric patients, mainly because if you give a block to a pediatric, let's say a 4 or 5-year-old, if you give a block with mepivacaine, they have a tendency, because they're kids, they have a tendency to bite through their lip, and they can cause, because they don't feel it. And so they have to be, I would be very careful about using bupivacaine in children because of that potential trauma to the tissues. Bupivacaine, carbocaine, we talked a little bit about that. It's an excellent drug when we're dealing with infection and inflammation. The problem is it typically is available without a vasoconstrictor. So it's a 3% without vasoconstrictor. There is a 2% that with 1 to 20,000 neocorbaferin, which is an option. But when you're dealing with inflamed and infected environments, what I typically do is I do a cocktail of local anesthetics, where I'll initially either give articaine or lidocaine, and then layer on top of that mepivacaine, because I want that penetration that you get from the drug that has the lower pKa. So mepivacaine is a nice one to have in your armamentarium. And as we go through this, I'll talk about considering getting these in the dental carpule that we typically use in a dental office. It's a very nice single patient use form, and you can have multiple different drugs available to you and choose one that works well in your hands. Prilocaine, Cetonest, I would say very similar in activity to lidocaine. What's nice about prilocaine, like mepivacaine, it's one of the least vasodilating of all of the local anesthetics. So for patients with significant cardiac history, you can give it without epinephrine or with 1 to 200,000 epinephrine. You have to give less epi, but still get fairly decent working time. And so for cardiac patients, prilocaine and mepivacaine are both really nice to use because of the decreased sympathetic tone you're going to get. Articaine is an excellent local anesthetic. We use quite a bit of this. It comes as 4% with 1 to 100,000, or it's also available in 1 to 200,000. Now, what's nice about articaine is that it has proven very good bone penetration compared to the other anesthetics. And for the way I see it, for an ER physician, if you're going to just trying to get people out of pain, you can give maxillary infiltration with this drug and get good anesthesia without having to give palatal anesthesia. Because giving palatal injections is quite uncomfortable, as we'll talk about in some of the demonstrations. But articaine is a great drug to do for maxillary infiltrations to get somebody through a painful event until they can get the actual dental problem solved. So I would encourage you to add articaine to your armamentarium as a treatment mode for maxillary teeth. Now, just be aware, we try not to use articaine a lot for blocks. There is some data to suggest that articaine has a little bit higher risk of neurotoxicity. In fact, if you Google septicaine, one of the things that comes up on your search is septicaine lawyer, because a certain percentage of patients who have had septicaine blocks will have permanent or at least partial paresthesia of the nerve after using that as a block. So I just have chosen in my practice not to use articaine as a block. I think you can use lidocaine and cetonest. These are drugs that will give you just as good an effect. It is the advantage of articaine, again, is about its ability to penetrate bone in infiltration. And so I would not recommend this drug to be used as a block. So what I use clinically, articaine, I don't use it for inferior obturative blocks. I use it for minor procedures, and it's certainly appropriate for pediatric patients, and you can avoid, like I said, palatal injections, and it's very excellent for getting for infiltration in the lower anterior mandible, because you can get central incisors anesthetized by just doing infiltration rather than having to do bilateral blocks because of the way the innervation occurs in the anterior mandible. When we look at how long do these things work, you want something in your situation, I would assume, that lasts as long as possible. And really, right now, your really only option is bupivacaine. And so I would encourage you to have bupivacaine as an option. Atidicaine, I love that. Duranest was a really fantastic drug, but it's no longer manufactured. Not because there was anything wrong with it. It's just because I think myself and like 2 other people in the whole country were actually buying the stuff. I thought it was a great drug. And it works very long, but unfortunately it's not available. So I would encourage you, the 3 drugs that I think, well, 4, that I think that you really should have in your little dental anesthesia kit would be lidocaine, articaine, mepivacaine, and bupivacaine. And that would be the ones that would probably provide everything you're going to need to be able to provide really good anesthesia service to patients in acute dental pain. Just remember, there's a reason these vasoconstrictors are in these drugs, and it's because all of your local anesthetics are vasodilators. The only one that's not a vasodilator is cocaine. Cocaine is actually a vasoconstrictor, but the rest, all of these are vasodilators. And so the least vasodilating are prilocaine and mepivacaine, and that's why they come either plain without additional vasoconstrictor, or they have lower amounts of vasoconstrictor, which is nice when you're dealing with patients with cardiovascular issues. There are intranasal mists that can be used. There's some data to show using these for managing pediatric patients for anterior like trauma, like if you have a kid who falls and knocks out some baby teeth or they're dangling and you just want to get them a little numb so you can get these things out of there so they don't aspirate something. These nasal mists actually are reasonably effective in giving anterior maxillary anesthesia. You just spray them in the nose, and because of the proximity of the anterior superior alveolar nerve, you can get the patients reasonably comfortable that way. And one of the things that's coming down the pike now, and it's being tested for in third molar extraction models, is bupivacaine impregnated liposomes. These are used as an infiltration to provide very long, up to 96 hours of local anesthesia, and definitely an opportunity there to avoid having to prescribe any analgesics. I think that and this may be something you're already utilizing in your ER for other types of blocks. The data on dental application is still coming. It's not approved by the FDA for doing blocks, but only for infiltration. but I think in your practice lifetime, you will be using this as a stopgap to get patients comfortable in acute pain situations. So ongoing clinical trials, it's not approved as a block. So the way this works is this is liposomes that are impregnated with bupivacaine, and it's injected in a solution of bupivacaine, and then gradually these liposomes will dissolve, release more bupivacaine, and it provides, long-term kind of anesthesia. So something to consider having in your armamentarium, and something I know that in our practice we'll be using soon, but I'm just waiting for the data to come out. So we're going to talk a little bit about anesthesia techniques, and when we're talking about anesthesia for dentistry, we're talking about the trigeminal nerve. And in particular, you're talking about the second and third divisions, the maxillary division and the mandibular division. And that nerve, it's a love-hate relationship I have with that nerve every day in my career, trying to get this thing tamed. And I'll tell you, you as ER physicians deal with the worst of it. Because when this nerve gets angry and a patient's in a lot of pain, it becomes very challenging to get profound anesthesia for all the reasons I just talked about. pH issues, the changing of the physiology of the nerve. And so I applaud you for doing whatever you can to get these patients out of pain. So first we'll talk about maxillary anesthesia. Almost all of maxillary anesthesia is done through infiltration. The cortical plate's not very thick. The anesthetics penetrate that quite well, especially articaine. And you can achieve pulpal anesthesia sometimes without even giving any palatal anesthesia at all, especially in pediatric patients because the bone is even less dense in those patients. When we look at where the landmarks are for these injections, I try to keep it fairly simple. I imagine that tooth, I imagine where the apex of that tooth is, and I try to deposit the anesthetic as close to the apex of that tooth as you can. And you're going to inject about a third of a carpule per tooth, and it's going to provide you really good, profound anesthesia on that tooth. Now, in maxillary anesthesia, a lot of people will talk about various blocks that can be done. For example, there's a posterior superior alveolar nerve block. But to be honest with you, I would encourage you to think more of individual teeth in providing infiltration in that area to provide anesthesia on that tooth. The PSA is a block that's done back further, back towards the tuberosity of the maxilla. The problem is with the PSA is there are potential complications there. It's very vascular. You have the pterygoid plexus is right there. You can get a lot of aspirations. You can get significant palpitations from epinephrine absorption in that area. So it's a block that you certainly can use, but I would encourage you to just use standard infiltration. So when we're talking about delivering local anesthesia to patients, there's basically separated into two main sets of injections. You have the maxillary injections in the upper teeth and the mandibular injections for the lower teeth. But I will tell you, as somebody who does a lot of surgery on the maxilla, these nerves are not very exactly where people say they are, because the nerve arborizes quite a bit. And so what I would say is that to really focus on the tooth that you need to anesthetize and trying to deposit local anesthesia as close to the apex of that tooth as you can. And that will give you really good predictable results. But we will talk a little bit about locations for PSA, MSA, and ASA blocks. But really, when you're looking at a specific tooth, you're trying to get the anesthetic as close to the root of that tooth as possible. So now, when you're giving these types of injections, you're going to need to be able to retract the cheek, because the cheek's going to kind of get in your way. We typically use something that's called a Minnesota retractor. You're probably not going to have something like that, so I would use a tongue blade. I think it's it's kind of shaped the same, and it'll be able to provide you access to where you need to give these injections. So when we're first talking about infiltrating in the maxilla, so we'll first talk about localizing maxillary posterior teeth like molars and premolars. With that injection, I'm going to have you open there, Russ. So one of the things you can use this to retract to get you a good look at those molars and premolars. And one of the things you'll notice that if a patient opens real wide, open real wide, Russ, it gets harder to retract in the maxilla. And so you you have them close only open about halfway, and you'll be able to retract much easier. And Russ will tell you, I'm not having to pull on his cheek quite as hard with not having him open real wide. And for the PSA, what you're trying to do is you're trying to get it back behind the second molar, usually the last molar in the patient's mouth, and you're trying to go back quite far and with an angulation towards the apex of that tooth. And that's going to give you the PSA. The PSA is going to give you a block that's going to numb up both the second molar and the part of the first molar. And it's a nice block also for wisdom teeth. But frankly, again, if I need, for example, if you needed to anesthetize this first molar, I would just be aiming right at the apex of that tooth. And that goes for all the teeth as you go around. You're really just kind of aiming for the apex of the teeth rather than doing some specific, trying to do some specific block. So again, in the maxilla, we're looking at infiltration of the individual teeth. Now we'll talk about the anterior superior alveolar nerve. Now this is a nerve that provides sensation to the incisors, canine, first premolar area. And again, with these injections, you're typically going to be trying to get your local anesthesia at the apex of the tooth. Now with anterior teeth, I will tell you, these are not comfortable injections. It's an area that that people don't, especially if the tooth is infected, it's going to be a very tender area to give these anesthetics. One of the things you can do to help make it a little bit more comfortable is when you're giving these injections. Now this is one where I probably wouldn't use my tongue blade. That's more for the posterior teeth. I would go with just my fingers here. And when you're giving the injection, lots of wiggle in here. Okay, so you're going to, in fact, when the needle first goes in, almost like a little tug you're going to give on the lip when you're giving that injection. Because that distraction is going to help so that the patient doesn't feel that injection quite as much. So for the anterior superior, you're going to be coming up into the depth of the vestibule, going about, probably to about the depth of about halfway on that short needle. And when you first inject into the tissues, you want to give a really good tug to that lip. And that really helps distract the patient, make it much more comfortable for the patient to receive that injection. One of the things I didn't mention is how much to give. Generally speaking, you're looking at, for these infiltrations, about a third to a half of a carpule of anesthetic for each tooth. And then as you go around, you can give, spread that out. But generally, it's about a half to a third of the carpule for the buccal, the cheek side of that injection for infiltration both in the PSA, ASA, and MSA. So the next injection we'll give is maybe one that you're not going to have to give very often. And the reason is oftentimes for an acute dental pain, giving infiltration in the maxilla from the cheek side is going to be enough to get the patient comfortable, because that's usually what you're trying to accomplish. If the patient's not comfortable enough, you may have to give some palatal anesthesia. I can tell you, all dentists will tell you it's one of our least favorite injections to give because they're very uncomfortable injections to give. Tissue is very tight, and that tightness of that tissue means that when you're injecting, there's lots of pressure, and the patients feel that. It's a very sensitive area to give injections in the palate. Now, one of the things you can do to make that more comfortable is using some counter pressure, and that's with either a tongue blade, or you could use a cotton applicator of some sort. And apply some pressure to the tissue right next to where you're giving the injection, and it makes the injection a little bit more comfortable. Now I'll show you in the mouth what we're talking about here. The greater palatine, turn towards me a little bit there, Russ. The greater palatine is, you can almost see the anatomy right here, this little indentation right below, kind of between the first and second molars. That is where the greater palatine is exiting the palate. So that's where the injection is going to be, right in that little indentation right there, just palatal to the first and second molars there. And again, when I talk about counter pressure, you're pressing on the palate and then injecting right where you put the pressure. And that will make it a little bit more uncomfortable. But expect those injections to be uncomfortable. And oftentimes you do not need to give that to get patients out of pain. You do need to give that if you're actually doing procedures where we need to take out a tooth or something like that. So we talked about the greater palatine and how uncomfortable that is, but the granddaddy of all uncomfortable injections has got to be the incisive nerve block. This is the right behind your central incisors. You'll see a little bulge. That is the incisive papilla, and that is where the nerve exits the maxilla. It is a quite a tender area, often not something you typically need to do. For an ER physician, I could see them needed to do that if they're putting a tooth back in position, if there was some trauma, that sort of thing. But for a typical dental infection, usually you're going to be able to get people comfortable with just the buccal infiltration without having to give the incisive block. So right there you can see Russ has a real prominent incisive papilla right there. That is where the injection happens. Very uncomfortable inject. I usually would never inject right on it. I would go right in that kind of crease right next to it. Again, counter pressure helps, pushing on it and then injecting. And the other option is to actually come from anteriorly through the papilla between the incisors and come this direction. But that means bringing a needle in front of a patient like that, and that has its own issues. So, but to be honest, for an ER physician treating some anterior maxillary tooth pain, oftentimes just providing good infiltration on the buccal is going to get the patient out of pain without having to give some of these more uncomfortable injections that you only really need if we're extracting the tooth or doing some surgery on that particular area. Now we're going to talk about giving blocks for the for the mandible and lower teeth. Just a few things about where to stand. You know, I stand as an oral surgeon. I stand when I do these things. I think standing is perfectly fine, and most of these patients will be on a gurney. I think having them somewhat upright, sitting up, sort of half supine is probably the best position. The key thing, unlike the maxilla posterior, where I said to not have people open wide, for inferior alveolar nerve injections, you want them to really open wide, because that's when you're going to really see the anatomy, and there are landmarks that are very easy to identify when they're open wide. You're going to want to use the longer, little bit higher gauge needle, so there's less deflection of the needle, and because this has to, you have to get the local anesthetic as close to that nerve bundle as you can. I usually like to retract with my finger because I want to feel the anterior ramus with my index finger. So here you can see the raphe right here, and then this little dipped in area. Every patient has that. Doesn't matter the size, kids, adults, this little pocket right here. And that's the area where you want to start your injection. And I like to come pretty far from the lateral because I want to feel, you're first coming in and you're going to feel the medial ramus. And I'll show this on a skull. You want to feel that medial ramus, and then once you feel that, then you're kind of changing your direction and sliding back. You're only going to go in about half of the needle. You're going to aspirate to make sure that you're not in the inferior alveolar vessels, and then you're going to give about half of the carpule of anesthetic. So it's coming lateral, feeling the ramus, changing, going at about halfway in, aspirating, injecting half the carpule, and then what you want to do is come about halfway out, inject about a quarter of a carpule, and then you're going to pick up the lingual nerve. So you're getting both the inferior alveolar nerve and the lingual nerve. The last injection you do after that with the last quarter carpule on the side, out on the external oblique ridge of the ramus, and this is where you're going to find the buccal nerve, and you're going to give a quarter of a carpule there. So there are three nerves that you're getting with this injection: the inferior alveolar nerve, the lingual nerve, and the buccal nerve. Coming in, half a carpule for inferior alveolar nerve after aspiration, halfway out for the lingual nerve, and then coming out for the buccal nerve. And that's going to get all of the teeth on that side of the patient's jaw, every single one of the teeth numb.
There's an additional point we would like to address regarding the number of carpules needed when we're doing the dental blocks. We have found in our clinical experiences that when patients present with the extreme dental pain or infection, it is not uncommon to require administration of additional carpules of local anesthetic in order to obtain adequate anesthesia. So I want to reiterate, be aware that in most emergency situations, you may need to administer 2 or 3 carpules of local anesthetic in order to obtain profound anesthesia.
The way you'll know you have a good injection is they'll have numbness of the lip, and they'll have numbness of their tongue. Now that doesn't mean they necessarily have numbness of the teeth, but it tells you that they are definitely, you got the local anesthetic in the right spot. The only teeth that will not consistently get numb is going to be the central incisors, and we can show a little different injection for that. So when, just to show you on the skull, where my finger is, as I'm putting my finger right here on the anterior ramus, right in the little notch that's right there. That just gives me a feel for where the anatomy is. And we're coming in from the side, right in that little landmark I showed you, and you can see where the inferior alveolar, this is right where the foramen is. So we're trying to get local anesthetic right in this area. I will tell you where people miss this injection is being too low. You want to err on the side of being too high. And then, because once the nerve enters the jaw, that's fairly thick bone there, and there's a tendency for that just not to anesthetize enough. So you want to be up high, and I think the other miss is going too deep. The nerve is not that far back, so you do not need to go to the hub of this needle. You're going to go about halfway, and you're going to be right where that nerve is. So if I can take this, Russ, and just show.
Sure.
Here you can see, that's where you're trying, that's the landmark, and you can see, just by looking at the needle, if you go all the way to the hub, you're going to be behind the mandible and you're going to miss. And actually, you'll probably be in the parotid gland, which is not where you want to inject. And so we want to be right there, right at that foramen, and you're going to get really good anesthesia. And you can see how that nerve's coming through and it's providing anesthesia for all of these lower teeth, except for these lower central incisors. Just a word about lower central incisors. They're difficult teeth to get numb with blocks. We typically do some infiltration on those. This would be something you're using for somebody who has some trauma, perhaps loosen those teeth. You're going to put a little bonding on to try to stabilize a tooth that's been luxated. So for doing this injection, you're just doing very much like you do for a maxillary infiltration, but it's an infiltration at the apex of the lower mandibular incisors. And probably about a half a carpule, a little bit of an uncomfortable injection, but it'll get all four of your incisors quite numb.
One of the key factors that Dr. Best had mentioned was, again, to remember to, when you're infiltrating, you want to aspirate. With the maxillary injections, it's not quite as critical to aspirate. It's still advisable, but not as critical, except for when doing the PSA or posterior superior alveolar block. When you're going back that far, you want to make sure that you stay away from a space called the pterygoid plexus. If you hit that during an injection without aspirating it, you will notice immediate swelling, and it's very unnerving.
Okay, so one of the things that we want to demonstrate is the use of a dental syringe versus the usual syringe you might use in an emergency room from a multi-dose vial. The advantages of the dental syringe is that you can obtain these single-use local anesthetic vials that are really nice for providing dental anesthesia. The other advantage is that there's quite a different variety of local anesthetics you can get that come in these single-use vials, and it'll allow you to utilize different drugs for different situations. The way this type of syringe is used, obviously, it's sterilized. It can be reused multiple times. It does have a little sharp harpoon on that will engage the stopper inside the cartridge, and that allows you to do an aspiration, especially for inferior alveolar nerve blocks, as we'll show you. But this type of syringe can be reused. You got to let the staff know this isn't thrown out. You'll go through a lot of your budget if you're throwing these out after every case. But you just have to re-sterilize and have it available. There are different needle sizes that you can get for this. Usually for maxillary injections, we're going with the these are both 27 gauge needles. We're usually going with the shorter needle for maxillary injections, but you'll need something a little bit longer for the injections in the mandible. And the way these work, you just basically break off the little cover over the business end of the needle here. You're going to put it in and you just screw that on. And then the carpule, you just pull back on the plunger and insert the carpule and engage it. And now that's ready to be able to use for an injection. And again, the advantage of that harpoon is it allows you to aspirate, especially for the inferior alveolar nerve injection where you potentially can be in a blood vessel. You want to make sure that you're not mainlining lidocaine with epinephrine in these patients. but instead are giving a block of the nerve. There are different color codes for depending on what the drug is. For example, the red striped are lidocaine, blue stripe is bupivacaine. We have mepivacaine, which is tan, and the articaine, which is a silver. There's different levels of epinephrine in the various anesthetics that you can get, depending if you have somebody with a cardiac history and that sort of thing. But I think that these are a really nice way to be able to give people anesthetic injections without having to use the multi-dose vials. So with the color coding of these needles, again, the yellows are a 27 gauge needle, a little bit thicker, nice for when you're doing blocks so that the needle doesn't divert in the tissues. The little thinner gauge blues, those will tend to diverge a little bit more in tissue. The problem with these is that the aspirations can be a little bit more unpredictable because it's obviously the needle size is a little bit smaller. Again, we typically use the blue, the shorts, and narrow needles on maxillary infiltration for the upper teeth, and then the longer, thicker gauge needle for giving blocks like the inferior alveolar nerve block. All right, having gone through your local anesthetic selections and also talked about the various blocks and techniques for using those various blocks, well, let's go to what our analgesic strategy for John. So what can we do for somebody who comes in with acute dental pain? Well, obviously, there's two main flavors of analgesics we're going to use, non-opiate analgesics and the opiates. Non-opiates are going to be your salicylates and your anti-inflammatories. And classically, we've thought of those as peripherally acting. Then you have your opiate analgesics with your agonists, your mixed agonists, antagonists. And we've always thought of those as kind of be centrally acting. And that's probably not completely accurate. But really, what I always tell our dental students is when you look at what causes the pain for somebody like John, it's inflammation. And so the key to figure out how to manage these patients is in the name. The anti-inflammatories are going to be the most effective drugs. And when clinical studies have been done to look at dental pain and how they can be managed, the anti-inflammatories have been shown time and time again to be the most effective. So they have excellent oral efficacy, they're relatively low incidence of side effects, low abuse potential. We don't have patients trying to score these drugs on the street. They're low cost, and they're the first-line drugs for managing dental pain. I think you all know how these drugs work. They block cyclooxygenase, the breakdown of arachidonic acid to prostaglandins. I always remind our dental students that remember that arachidonic acid doesn't go away when you block cyclooxygenase. It's going to get shifted over to the lipooxygenase pathway, to leukotrienes. And for asthmatics using anti-inflammatories for long periods of time, that can start to interfere with their ability to control their asthma. But for acute dosing, for the kind of thing you're doing for an episodic dental pain issue, usually that's not going to be a problem at all to provide anti-inflammatories and not cause issues with asthma. As you know, there's two main isoforms of cyclooxygenase. You have COX-1 and COX-2. COX-1 is the ubiquitous form. It's involved with maintenance of gut flora. It's involved with renal function. It's involved with platelet aggregation. And that ideally is not the one we really want to block. What we want to block is COX-2, which is the inducible form. That's a form that is induced in response to trauma and has a role in acute inflammation. The problem is that most of the drugs we use block a little of each. And so we look at the list. Aspirin actually is better at blocking COX-1 than COX-2, and that's why aspirin really isn't a very effective analgesic for what we need. What we wanted is a drug that's going to block COX-2. And when you go down the line, you get to drugs like ibuprofen and Atotolac, which actually are better at blocking COX-2 than COX-1. And then you get to the Coxib family, which are the best at blocking COX-2 activity. But really, for bang for the buck, you can't go wrong with a drug like ibuprofen. It's just extremely effective at blocking COX-2. And in the short term, for acute dosing, is very safe and really is the go-to drug in our practice for managing postoperative dental pain. Now, the COX-2 agents, they're pharmaceutical companies spending a lot of money developing these drugs, and for a good reason. We have patients, as you know, that have chronic pain that we want on anti-inflammatories for long periods of time, and the COX-2 agents should have fewer side effects, renal, gastric, and platelet side effects when taking these drugs for long periods of time. The problem is they're very expensive, and they really don't, the COX-2 agents don't really, for acute pain, don't have any significant advantage over much cheaper over-the-counter anti-inflammatories. They have the same contraindications as any other NSAIDs, and the problem, as you know, when some of these drugs were introduced, was increased risk of stroke and MI. So you can go down the list of the COX family. You have Vioxx, which end up being taken off the market. Celebrex certainly around, meloxicam. But again, for acute dental pain, these drugs don't really make a lot of sense to me. They're a lot more expensive, and I don't think they offer any real significant advantages over just plain ibuprofen. There is a COX-3. This is a splice variant of COX-1, and the human clone has been found. And actually, it's thought that this is a splice variant from COX-1, and it may be the site of action of acetaminophen. It's involved with fever mechanism and maybe like I said, how Tylenol works. When we look at individual groups of drugs, we can start out with the salicylates, aspirin, as I said, and diflunisal. These drugs really don't have a place in my armamentarium for managing dental pain, just because they're more COX-1 selective, and it's because they have all these potential side effects, GI issues, issues with affecting platelets and causing issues with peptic ulcers, renal issues. So these drugs, I include them for historical purposes, but really not a drug that you're going to use. You're much more likely to use some propionic acids, which have really become the workhorse for anti-inflammatory activity for dental pain management. And ibuprofen being the leader of that, because it's just, the dosing schedule is nice. It provides fairly good COX-2 inhibition, and it's just really cheap. The problem is, most of the time, is that patients just have this perception that it must not be very strong because I can buy it over the counter. So I find myself sometimes just prescribing an anti-inflammatory like a diclofenac, like Voltaren, just because if a patient has a prescription and they get it filled, they somehow think that this must be really strong and good. Even though there's no evidence to show that that's any better than ibuprofen, there's a therapeutic benefit, just a placebo effect of the patient thinking they're getting some fancy, really expensive drug. And then I can see that there's roles for that periodically. But when you look at the propionic acid, they're going to have all the same potential side effects that you can get with any of the anti-inflammatories. But again, for acute pain dosing, like you do for a dental infection or acute dental pain, you're only going to be prescribing these for at most about a week, or probably even less. And in that period of time, you're not going to see a lot of these side effects in most patients. The indols are interesting. A Totolac loading, a very nice anti-inflammatory. Another one that periodically I will use if a patient just doesn't feel that, over-the-counter naproxen or ibuprofen is going to be good enough for them. Totolac is a nice one to go to. It's been shown in dental pain models to be more effective than narcotic pain medications. And so Totolac would be another one that I think would have in my quiver. And then, of course, you have Ketorolac, Toradol, a very effective anti-inflammatory. And the big advantage of that is it can be given parenterally. So if you have a patient in the ER and you want to rapidly get anti-inflammatory on board, I would encourage you to use Toradol. Bleeding is not an issue. Virtually every third molar patient that's done in my office with IV sedation is getting 15 milligrams or 30 milligrams of Toradol intravenously before we take out the teeth, and we do not have an issue with bleeding. So I would encourage you, I think Toradol is a very nice option. Obviously, there's expense to that, but for a rapid way to get anti-inflammatories on board in an acute situation, it's a nice option. And then Tylenol, we will use Tylenol mainly to augment anti-inflammatory analgesia. And so what I'll oftentimes have patients do is ping pong back and forth between a drug like ibuprofen and Tylenol, even just 400 milligrams of ibuprofen followed by over-the-counter Tylenol followed by 400 milligrams of ibuprofen, just back and forth. Every couple of hours the patient's able to take something, and oftentimes you can nurse the patient through a painful episode until such time as definitive treatment can be provided. And then we get to the opiates. You have the laundry list of opiates. I try in my practice to limit myself to codeine and hydrocodone or perhaps tramadol. I do not prescribe a lot of these other medications just because of all the problems and the issues that we started out the lecture with. I will tell you that most patients do not need these medications for an acute dental episode. Anti-inflammatories are going to be more effective. I think the key thing is, and this is what we train our dental students, is not to prescribe to the worst outcome, but to prescribe to the average. And that means, like if I do a set of wisdom teeth, where I used to prescribe 20 of Vicodin with a refill, I'm now only prescribing 5, or none in many cases. So we need to really rethink prescribing these, because the problem isn't the medications you prescribe and the episode that you're managing as an ER physician. The problem is the medications that are left over after the episode is done. And those medications hang around, and they end up in medicine cabinets. And unfortunately, those don't always end up in good places. They can end up with an adolescent at a party, and then we have the problems that evolve from that. So I would encourage you, if you do use these to help manage dental pain in an ER setting, that you prescribe very few and only enough to get them to the point where they can get definitive treatment. And how do these drugs work? They work through, obviously, opiate receptors, and there's different opiate receptors in different locations. The mu receptor is the one that's the problem child. That's where the profound analgesia, but also the euphoria and some of the addiction comes from. Whereas kappa is more in the spinal cord. And so what you're seeing now is pharmaceutical companies trying to develop synthetic opiates that may target one or more of these receptors to try to have some analgesic effect without having the euphoria and the addiction problems. Tramadol is an interesting drug. It's a weak opiate agonist, but it has some serotonin or norepinephrine reuptake inhibitor activity. It has been shown in dental pain models to be as effective as narcotic pain medications. I will tell you, I like this drug for the patient who just seems to not be able to take anything. The ones that are allergic to all the NSAIDs you know how to prescribe. They're allergic to all the narcotics that you know how to prescribe. They're allergic to dairy, non-dairy, and human tears. These are the patients that really do well with tramadol. Be aware, though, you cannot prescribe this to this drug to any patient who has a seizure history, because it can affect their seizure threshold. It also is available as a combination with acetaminophen and Ultracet. Then you have your mixed agonist-antagonists. We actually used to use these a lot more than we do now, and I don't know really why they kind of fell out of favor. There's Talwin that has a little less mu effects, and there's actually a Talwin NX that has naloxone in it. And these drugs like Suboxone that have naloxone combined, the reason they put naloxone in these things is naloxone, if you take that drug orally, there's a very significant first pass effect. And so when you take a Talwin NX and you swallow it, goes through your digestive tract, you get this first pass effect, you lose off the naloxone, and then the pentosocine can do what it does. But if you try to inject it, or if you try to snort it, the naloxone does not get the first pass effect, and that blocks the high the patient can get. And so that's why these drugs like Suboxone and pentosocine are offered this way, is to prevent the abuse of the drug through injection or inhalation. Nubane is a drug, IV drug that we've used in the past, and it's also a mixed agonist-antagonist. And then obviously you have your antagonists, naloxone and naltrexone. I think I always tell my dental students it's important. The worst drug you can prescribe to any patient is a drug they can't afford, because it's not going to be effective. And so to understand the costs of these things. And so anti-inflammatories like ibuprofen and naproxen, they're cheap. Especially you get them generic, you know, you go to Costco and you can buy a wheelbarrow of this stuff for 15 bucks. But you start getting into the Coxib family, and these drugs can get quite expensive for patients. So I think it's important to try to keep the cost down, and get, as long as unless there's data to show one's better than the other, I go for the cheapest. And so I probably prescribe much more ibuprofen than I do naproxen, just because I like to be able to go down on my dosing if need be. What's new as far as analgesics? Well, you're going to have certainly more COX-2 selective agents that are going to be coming down the pipeline, and there's people trying with opiates in injections, so local anesthesia that have opiates in them to try to help with pain. Caffeine as an additive actually isn't all that new, and we know that augments analgesia. Norceptin they're new opiate receptors that have been cloned and may have some therapeutic benefit. Substance P blockers are out there. But I think one of the most interesting things, and I think something that we'll definitely be using more, and I talked about it a little, is the ultra long-acting local anesthetics, and that's the liposome impregnated bupivacaine. And I think that we'll be using that as part of our strategies in the future. But again, one of the things we have to understand and have to incorporate in our daily routine is an understanding of the abuse of the prescription opiate abuse problem, and trying not to contribute to that by using other techniques. Preemptive analgesia, although it's not probably something very significant for ER physicians, because usually you're coming in and the patient's already in pain. But the concept of this is to provide anti-inflammatories and steroids prior to a surgical event to decrease postoperative pain. And this can be very, very effective strategy in decreasing how much postoperative pain patients have. But again, because of what you do, probably isn't that critical, unless you're doing something where you're reducing some kind of a fracture or something where you want to, you know there's patients that can have some significant postoperative pain. Certainly, preemptive analgesia with NSAIDs would be appropriate. Now, one of the things that I know I interact with ER physicians that I work with at the hospitals I work with are a lot of dental infections, and having conversations over the phone with ER physicians and talking about how severe an infection a patient has and which cases are going maybe admissions, which are ones that can be followed up in the office. So I just want to talk a little bit about infections and managing patients with dental infections. So obviously you're going to take a history. You want to know, when did the symptoms start? So for example, if symptoms of swelling started this morning, there probably isn't a space abscess there that I can drain. It's probably just all cellulitis at that point, and there isn't really a drainage to happen. Versus an infection that's been there for 4 or 5 days and the swelling's there, then there's probably a space abscess that really could benefit from drainage. And what's the pain level? You very rarely, if you have a swelling of the head and neck and there isn't pain with it, very rarely is that a dental infection. Dental infections, the one thing that's almost universal with all of them is pain. If there's not pain, then start thinking about potential salivary issues, tumors, hematomas, those kinds of things. But dental infections are almost always have the sign of pain. And then obviously we want to know if there's fevers or chills, any kind of systemic effects from the infection. One of the key questions you need to ask these patients who have a dental pain, if they have any dysphagia or dynaphagia, any pain or difficulty with swallowing, that gets me more concerned. That's sounding more like an admission to me. Somebody might need to go to the operating room tonight. Because we're concerned about the airway and potential airway embarrassment. Is there any drainage? When you look in the mouth, if a patient has a dental infection and you see pus coming out from a little pimple next to the tooth, That's a good sign, because dental infections that are draining usually don't get out of control because they're able to drain. It's the ones that aren't draining, that are going into deeper into the tissues of the neck, into the up underneath the jawline. Those are the ones that potentially can lead to airway embarrassment and potential problems. And obviously, you want to get an assessment of their hydration, their diet, getting labs to get a feel for how sick the patient might be. And then obviously any medical contingencies, diabetics, stuff like that, that can really impact our decision making about admission versus somebody you can manage as an outpatient. Obviously, what's their general appearance? You know, I get sent over patients that are this big emergency, and they come in and they're chit-chatting and joking around with my staff. That just tells me something. Whereas otherwise, you have the patient who comes in and looks like they have the worst flu ever, and they look septic. They just don't look well. And then obviously, you're going to do a complete head and neck exam. Extraorally, you want to look for nodes. Where is the swelling? What's the location? Is there any crepitus? Is there any erythema? What's the capillary refill look like on the tissues? Because that's the kind of thing that we need to know to make decisions about how we're going to manage these patients potentially. When you're examining intraorally, is there trismus? All right? The problem with somebody who has dental infection with severe trismus is we really have a difficult time assessing what the airway is like. What's the uvula doing? We can't see back there. As soon as somebody has a dental infection and has trismus, we're going to need to get a CT. We want to see what's going back in the posterior tissues. Is there any swelling that's discernible intraorally? What's the uvula? Is the uvula at midline, or is it shifted over? What's the pharynx look like? Is there any drainage? Is there an obvious source? And one very simple exam you can do on any patient with a dental infection that comes to your ER is take your finger or take a tongue blade and push down on the tongue. All right? Push down on the tongue. Because if they have a sublingual abscess, they're going to climb out of the chair. And that is an important thing, because sublingual infections are pretty much almost exclusively drained in the operating room, because it's a very hard space to get at, because there's lots of stuff going on there in the floor of the mouth. So determining if somebody has a sublingual infection, if you call an oral surgeon at night and say, I think I got a patient with a sublingual infection, you're going to get their attention, because that's the type of infection that can spread into bad places and become problematic fairly rapidly. For imaging for these cases, Panorex X-ray for some cases, but I would say for anybody who has some space occupying abscess, we will want to have CT. But for somebody who just has no swelling, and basically it's just your routine dental pain, a Panorex is going to show you, the source of the tooth and be able to kind of help you, guide you about where to send the patient the following day or that day for dental treatment. If you don't know the source, like you're looking in the mouth, the patient has pain, you can't find a tooth, then you've got to start thinking about other stuff that this could be causing the problems. There's obviously pathology, in particular salivary gland pathology, and sinus disease. I can tell you there are plenty of patients who were treated for dental pain with dentistry when really they had a sinus infection all along. So when you get that CT, oftentimes that'll give you clues about sinus disease. But remember, sinus disease can cause a lot of dental pain. So if you have teeth that look fairly normal, like there's no decay, there's no obvious things, and they're having, like all the teeth are percussion sensitive, and you have a CT that's showing sinus issues, probably the call isn't to oral surgery. The call should be ENT, because you may have an acute sinusitis. And think about salivary gland obstruction, particularly the parotid or submandibular glands. Those ducts can get obstructed and produce fairly significant swelling. They can be a little sore. If there's no obvious dental source, think about potential gland obstruction. And then trauma, that goes without saying. And then there are various developmental and tonsillar issues that can cause swellings in the mouth. And then keep in mind about temporomandibular joint dysfunction and pain. That can also cause a fairly significant amount of jaw pain. Now, I just want to go through some of the anatomy here and trying to connect a clinical presentation with where the infection is at. Because as an oral surgeon, what I really like to know is where is this infection at? Because that's how I plan what treatment I'm going to need to do. Is it something I can manage as an outpatient, or is it something I have to manage in-house? So I'm going to show you some different views. I'm going to jump through these. You guys are used to reading CT, so you kind of know these different spaces. But really, what happens with dental infections, when the pulp of the tooth becomes necrotic, and usually bacteria will invade this necrotic tissue, and it just becomes a breeding ground for bacteria. And that infection will escape out the apex of the tooth and then start to spread into the adjacent tissues. And so these localized swellings, they can be swellings that are right over the tooth. Like if you have a swelling that's right over the tooth, we call it a subperiosteal abscess. If it's in the mandible, some people will call it a mandibular space abscess. These are routine infections, something easily managed as an outpatient. Oftentimes, these will spontaneously drain on their own. If you numb them up, there's nothing wrong with just taking a 15 blade and just draining this. You don't have to leave a drain in it, but you'll get frank pus out of there, you'll drain it out, and they'll almost immediately feel better because of the pressure that's built up in this tiny little abscess. These are very straightforward to manage. Obviously, nothing that needs admission. But then when you start to get into a cheek swelling, there are different concerns about cheek swellings. When you look at the swelling, if you have a swelling that's like between the angle of the mouth and the anterior ramus, like right in here, that's what we call the buccal space. It's an infection that's drained out lateral to the buccinator muscle, and that infection is fairly easy to manage as an outpatient. Not something that necessarily needs admission, does not typically lead to airway embarrassment, but usually once you remove the source, the infected tooth, or do a root canal in the tooth that's causing the problems, these are fairly easy to manage. Now, if a patient has trismus, they can't open their mouth. The reason for that is that the infection or inflammation is irritating one of the big muscles that close your jaw. Mainly, we're talking about masseter or medial pterygoid. And so when somebody can't open their mouth, I right away think that that space is probably involved at least somewhat. So that can be a submasseteric space infection, that can be a pterygoid space infection, or it could even be a deep temporal space infection where the temporalis is affected. Now, these infections are pretty severe and require a CT to truly evaluate, and if they're accompanied by any kind of dysphagia, these may be patients that are admitted and potentially even have to go to the operating room for intraoral drainage. This is just an example of a temporal space infection. You can have infections that are deep to the temporalis or superficial to the temporalis. If it's superficial, you'll actually have a swelling. It looks like a little chestnut sitting right up here in the preauricular area, and that is a pretty significant infection and almost always requires an OR drainage for that. You also have little canine space infections. These are right over the muscles of facial expression that are right here. Exquisitely tender infections, right under the alar base of the nose. That comes from lateral incisor, maxillary incisors, canines, first premolars. Very, very painful infections, but routine and very easy to treat. The problem with these infections is when you give them local anesthesia. This hurts a lot because the problem here is you get a lot of pressure and swelling up under the periosteum in a very sensitive location. There are a lot of nerves there. And so when you have this very sensitive area, and it's part of the reason it's painful is all the pressure that's built up there, and now you're adding fluid with local anesthesia, it's very uncomfortable. So if you're dealing with a canine space swelling and you want to anesthetize them, what I would encourage you to do is do it in stages, where you just give a little bit of anesthetic, come back, give a little bit more, and gradually get it in. If you try to blow in an entire carpule of local anesthetic, which is roughly about 2 cc's of a local anesthetic, you're going to have a very, very uncomfortable patient. But this is an easy thing to drain, just a vestibular incision right over the swelling, and it's fairly easy to manage. Submental space infections, these are right up underneath the chin, kind of rare. They come from the central incisors. again, something that easily could manage as an outpatient in any oral surgery office. Now the big ones. We talked a little bit about sublingual space infections. This is the infection when you press on the tongue, it's uncomfortable, and that's because the infection's sitting above the mylohyoid, which is basically the floor of the mouth. And the problem with this infection is it has a tendency to spread to areas that threaten the airway. And so this is an infection we treat fairly aggressively. It is not one, and this is a very important point, this is not an infection you drain intraorally. You do not want, and you'll see the swelling. It looks like a little frog belly down there. And you do not want to be sticking something in there to drain this, because there are a lot of anatomic structures there. You have the sublingual gland, you have the submandibular duct, you have the lingual artery, you have the lingual nerve. All of those are all in this compact area. And if you blindly go in there to drain this infection, you can cause more trouble than you're solving. This is an infection that is drained extraorally. You come from below the mandible, you come up through the platysma, through the mylohyoid, and drain the infection from below. That way you avoid all these structures, and you also get dependent drainage. And so gravity will help this drain. So do not drain these, attempt to drain these infections intraorally. You will have problems and potentially have an issue. These are drained extraorally, and it's typically done in the OR under really controlled circumstances. Now, if you have a swelling that's below the inferior border of the mandible, so you feel the inferior border of the mandible and the swelling's down here, not up here like a buccal space, but down below your chin, below the border of the mandible, that's the submandibular space. That's an infection that's below the mylohyoid, but underneath the platysma, all right? And these are infections that are pretty significant, infections that are usually going to be an admission and have to go to the operating room for an extraoral IND and removal of the source. So submandibular space infection. I can tell you, I've had a lot of times where docs have told me I've got a submandibular space infection and the swelling's here. You know, if it's above the inferior border of the mandible, it is not sub. That's a buccal space infection, not a submandibular space infection. And so what happens to these patients when we drain them? We're just going to put drains in. We're going, typically from extraoral for submandibular and sublingual, we're going to drain the infection and leave a drain in there, usually for at least 24 hours. And then the most important thing, by far the most important thing, is get rid of the source. We're going to take out the tooth that is responsible for causing the space infection. Now, another one to be aware of is a lateral pharyngeal swelling. Now, what you'll see with a lateral pharyngeal swelling is you'll see a swelling back by the tonsils, but it'll be smooth. It'll be a smooth, domed thing. Not like your typical tonsil infection that I'm sure all of you have seen, which is rough and has those corrugated areas with pus coming out between the tonsil. This is smooth swelling, and the uvula will be displaced to one side, and this can come from a tooth. And so that is something that we would drain. That's usually going to be something we do in the operating room, and we'll do an intraoral drainage to get that done. And then we get to the one that, you know, I've gotten, for every call, I get 10 calls for a Ludwig's for every, maybe 20 calls of Ludwig's for every one that I've actually seen. It's not a common thing that happens. But to be Ludwig's, it has to be bilateral submandibular, bilateral sublingual, and submental involvement. And so that's a lot of swelling. All right, it cannot be on one, it's not on one side, it is bilateral. And the thing about Ludwig's, you know, this diagram shows it all yellow like that's full of pus. It's not. What Ludwig's is, they usually have an infection in one of those spaces, but it's producing a profound inflammatory response. So the problem with Ludwig's is this diffuse cellulitis. For example, when I've drained true Ludwig's, you usually get very little, if any, pus out of there. What it is cellulitis. It's this huge inflammatory reaction. The problem is that is a dental that's truly an emergency, because the airway, and I've had patients where I'm sitting there talking to them and it's getting worse as I'm watching them, where their tongue starts to get stuck on the roof of their mouth because the swelling is pushing their tongue up and back. And the problem is they get to the point where it's very, very difficult to get them intubated in the operating room. We've had to do emergency trachs on these patients, or crikes on these patients, because they lose their airway. So this is one, if you see bilateral swelling like that that's rapidly worsening, we want to get very aggressive about treating, taking to the operating room, getting drainage, getting on antibiotics, and we also give them pretty high dose steroids to get the swelling under control. So how do we treat these infections? We're going to give them antibiotics. We want to get surgical drainage, but by far the most important thing is removing the source. We have to get the source out, and that is either by doing what's called a pulp extirpation, which is basically the first step of a root canal, or by extracting the tooth. Now, when we choose antibiotics, keep in mind that over time, dental infections go from gram-positive and aerobic bacteria to more and more gram-negative and anaerobic bacteria. They're always a mixed bag, but early on. So if you have a dental infection that started this morning with a little swelling right over the tooth with a lot of pain, really your main things you have to cover are you're going to get your gram-positive aerobic, usually gram-positive strep. Beta hemolytic strep are going to be the main bugs that are the source. But if you have an infection that's been there for 4 or 5 days, then you've got to start making sure you have some gram-negative anaerobic coverage, because they're going to get more and more anaerobic and gram-negative as they age. The main bacteria we're talking about here are going to be the strep, up in that gram-positive cocci, and then down to the Fusobacterium and Bacteroides. Those are the ones we want to make sure we're covering. So how do we choose an antibiotic? We're going to, you have to first decide, am I covering some early mild odontogenic infection? Is this mild to moderate, or is it a severe multi-space infection? And obviously, we're going to consider what the patient's medical status is and the expense. So for acute mild odontogenic infections, oftentimes amoxicillin is going to be more than enough. You're covering the gram-positive alpha hemolytic strep that are there. If there's some question about pen allergy, you could go to something like Keflex. If you're pretty confident they're pen allergy, you can go to something like Azithromax. Will be plenty to cover them. As we get to mild to moderate odontogenic infections, then we got to start covering our anaerobes. So we're going to go to something like amoxicillin and metronidazole. I call it the poor man's clindamycin. All right, and that'll be 3 times a day, and that's amoxicillin and metronidazole is going to cover almost identical to what Clinda covers for half the cost. Clindamycin certainly would be an option, 300 milligrams, and I would go up to 4 times a day. I don't like the 3 times a day. If you've decided you're going to give the antibiotic, just give the antibiotic. Let's do this. And then another option would be Augmentin, and you could do the 500s or the 850s. That's up to you. But those would be the 3 things as far as outpatient management of a dental infection that's moderate to severe or mild to moderate. Those would be the extent of it. When we start to get into severe dental infections with multi-space, these are not managed as an outpatient. They're managed with IV antibiotics. They're managed in-house. We're typically going to use Unicin, which is Ampin sulbactam, or clindamycin. And we have sometimes we've been even using combination of Clinda and Flagyl and double covering the anaerobes, because we're seeing more and more of these infections that just aren't. It used to be not that long ago. It seemed maybe 15, 20 years ago. You give them clindamycin, and this thing was better in a day. And we just aren't seeing that. We're seeing more and more kind of resistant strains. And so sometimes we're actually double covering with some Flagyl. But again, the antibiotics are important. Choosing an antibiotic is important. But the most important thing is you got to get rid of the source. So if you have a patient in the ER that's going to be managed as an outpatient, find somebody, develop relationships with your local oral surgeons, somebody that's comfortable taking these patients, and let's get the source out of there so they don't keep coming back, having to have these infections retreated. How long do you have that patients on antibiotics? There's no real hard and fast rules. I generally think that if you remove the source, maybe 3 to 5 days afterwards is all you need. I don't believe in this 10 long flogging courses of antibiotics. That's when you get into the antibiotic-induced colitis and all the potential complications associated with that. So the key thing here is antibiotics do not replace surgical and endodontic treatment of the source, and prompt removal of the source is more important in my mind than selection of antibiotics and all these other things. And that means that I would encourage you to develop relationships with dentists and oral surgeons in your area that are willing to take these patients. And we understand these patients are sometimes can be a challenge to find a home for because of payer status and all these sorts of things. But you know, all it takes is for the dentists in your community, everybody to do their part a little bit, and we can manage these patients. It's not that hard. We're certainly do it here in our area, and I'm sure if you develop relationships with people, you'll be able to have people that are willing to help you get these patients care. And just in closing, I think the important thing again is to, you know, which antibiotic you use isn't as important as making sure that we're getting these patients treated definitively. And close follow-up is always important, and making sure these patients are followed up. And I leave you with a final thought, and that's from the man who trained me, Bob Shapiro, back in the University of Rochester in New York, is that don't let the sun set on pus. I think that's a word to live by, and I'll leave it at that. Thank you.